Good morning, and welcome to our 7th session of the Evidence into Practice Luncheon Series. Today we have Dr. Mike Pauldin, Assistant Professor at the School of Public Health at the University of Alberta, and he's going to talk to us about advanced methods in economic evaluation.
Yep.
Thank you.
Thanks very much. Perfect. Okay, so I'm Mike Pauldin. I'm a health economist at the University of Alberta. Today I'm going to give an introduction to two quite advanced methods in economic evaluation, probabilistic sensitivity analysis and value of information analysis. The ordering here is the wrong way around. Really, you need to know how to do a probabilistic analysis before you can do a value of information analysis. So, the overview of the talk. First of all, what is a probabilistic sensitivity analysis? What is a value of information analysis? And then I'm going to finish by talking about some of the implications for health policy. Now, before we begin, I'd like to just make a quick note on ISAs. How many people here know what an ISA is? Just a show of hands. Has everybody heard of an ISA? Anyone not heard of an ISA? Yeah. Anyone not sure if they've heard of one or not? Okay. So ISAs are quite a common standard outcome in cost-effectiveness analyses, the incremental cost-effectiveness ratio. How much extra does a technology cost divided by how many extra benefits that technology provides? And the lower the ISA, the better. But ISAs are problematic. They have some difficult statistical properties because they're ratios. They're non-unique. They have the problem of discontinuity. So what health economists have been using the last 10 or 20 years is an alternative to the ISA. It's not quite caught on in policy circles yet, but it has the same, it results in the same decisions as an ISA, it results in equivalent decisions, but it has much nicer statistical properties, and that's something called incremental net monetary benefit. So for the rest of this talk, I'm going to use incremental net monetary benefit. And for those of you who are comfortable with ISAs, don't worry, it's not more difficult to use net benefit. The ISA decision rule is to say that something is cost effective if the ISA, so that's the incremental cost divided by the incremental benefits, lies below some threshold, lambda, $50,000 per QALY, maybe. Well, when you use net monetary benefit, it's just a rearrangement of this rule. It's mathematically identical. What we're saying is something is cost effective if the incremental benefits that some technology provides multiplied by that willingness to pay for the benefit minus the costs. If that is positive, then we consider something to be cost effective. Right? So just for example, suppose that the incremental benefits are 2 QALYs. Some technology provides you with 2 additional QALYs, and we value QALYs at $50,000 each. Well, then we'd multiply those together. That's $100,000. We subtract the costs. If it costs less than $100,000, well, that's a good thing. That's something that's cost effective. And if you were to work out the ISA, you'd find that that's below $50,000. So they're completely equivalent. The reason I'm talking about that is that using ISAs when you're doing a probabilistic sensitivity analysis is quite difficult. It's much easier to use incremental net monetary benefit. So what is probabilistic sensitivity analysis? I'd like to use a very simple example in this talk, a model, a Markov model, with 3 states: healthy, sick, and dead. And we have transitions between these states. So patients might move from the healthy state to the sick state, or back to the healthy state. Patients that are either healthy or sick might die. People who are dead don't tend to move back to healthy or sick. You tend to just stay there. And when we build a model, we have to parameterize that model. So the first thing we put in are the probability parameters. So what is the probability on any given model cycle of a patient who is healthy remaining healthy? What's the probability of a patient who is healthy becoming sick? What's the probability of someone who is sick dying? We also need to parameterize the costs. So typically we would assign a cost to each health state. So there is a cost to being in that healthy state. Perhaps you're receiving drugs while you're in that state. So every month or every year that you spend in that state, you're incurring costs. There's a cost to being sick. There might be a cost of being dead. Usually it's quite cheap to be dead. And also we have utilities assigned to these. So when you're healthy, you'll have some utility typically between 0 and 1. You can have negative utilities, but when you're healthy, typically it'll be positive. When you're sick, you'd expect your utility to be lower, and when you're dead, your utility is 0. So this is a very, very basic economic model, very generic model. And what many of you will have seen so far is what we call a deterministic analysis, which is where we just put fixed values on all of those probabilities and costs and utilities. Everything takes a fixed value. There's no consideration of uncertainty in these values. And it follows that there's no uncertainty in the model results. If you put fixed values in, you're going to get a fixed value out. So for the remainder of the talk, we're going to consider a very simple example where there's two hypothetical treatments, treatment A, treatment B. We're going to use that simple model with 3 health states, healthy, sick, dead. We're going to estimate the total costs, total QALYs for each of these treatments and consider which one is cost effective. And we're going to run the model for 12 years. We're not going to use discounting, but you don't need to worry about that. So here's treatment A. And I've just put in some arbitrary numbers, so you can see that if you are healthy in any given year, you've got a 70% chance of remaining healthy for the next year. You've got a 20% chance of becoming sick in the next year, 10% chance of dying. So very, very simple numbers. And I've put in some costs as well. Every year you spend in the healthy state costs $5,000. If you're sick, that's $12,000. Doesn't cost anything to be dead. Get no utility if you're dead either. That's treatment A. What about treatment B? We have a lower probability now of remaining healthy. So treatment B is not quite as effective as treatment A. More patients are becoming sick. More patients are dying. It's also cheaper than A. I've assumed that the cost in the healthy state is lower, and in the sick state, the cost is lower. And I've also assumed that the utility is higher. Maybe there's fewer side effects with treatment B. So just looking at this, can we see which is cost effective? It's not obvious. You know, treatment B is less effective, but it's cheaper and there's fewer side effects. The utility weights are higher. So we could do a deterministic analysis. So here we have treatment A, treatment B, and we've put all of these probabilities in, all the costs in for each state, the utilities for each state. And we find that over 12 cycles, the total costs for treatment A are $45,000, for B, $27,000. So A is a lot more expensive. But you also get more QALYs. You get 2.99 QALYs instead of 2.55. So what most of you will have done to date is calculate the ISA at this point. You would say the incremental costs are $18,000. The incremental QALYs are 0.44 QALYs. So the ISA is $40,000 per QALY. And that looks quite cost effective. What I'm going to do in this presentation is calculate the incremental net monetary benefit. And because that ISA is below 50,000, you know that if you use a 50,000 per dollar threshold to calculate the net benefit, that it will be positive. And in this case, it's $4,000. So just so you know how to interpret this, if that incremental net monetary benefit is positive, that means that treatment A is cost effective. It also means the ISA is below 50,000. If this is negative, it means treatment B is cost effective. And if you were to calculate the ISA, it would be above $50,000 per QALY. So in the deterministic analysis, A is cost effective. Decision makers should pick treatment A. Okay? Now, what about a probabilistic analysis? In a probabilistic analysis, each of these input parameters is assumed to be uncertain. We don't just give them a fixed value, we give them a probability distribution. And it follows that the model results are also uncertain. So how do we estimate the model results? We use a technique called Monte Carlo simulation. Basically, you draw a value from each of these probability distributions. So each probability parameter has been assigned a distribution. Each utility parameter has a distribution. Each cost has a distribution. And we draw a value from all of these distributions. And we put those values in the model. We run the model. And we get a result. But we don't stop there. We then draw new values from all of the distributions. We run the model again. We'll get a slightly different result. And then we do it again and again. And if you keep doing that enough times, thousands of times, you'll have sampled across all of the distributions. And then you average over all the results. So that's the method that we use. It's Monte Carlo simulation. Now, of course, it matters what distributions we assign to all of these parameters. And the type of distribution and the parameters that we use in that distribution depend upon the type of parameter that we're dealing with. So whether it's a probability, or whether it's a cost or a utility. So probabilities are typically assigned at a beta distribution, yeah? Or I think in North America you call it a beta distribution, but I'm British, so I call it a beta distribution. Costs are usually assigned a log normal or a gamma distribution. And utilities are usually assigned a beta distribution, but sometimes what we would do is flip it and model the disutility as a gamma distribution. I'll explain that again in a minute. Now, all of these distributions look slightly different. So why do we use a beta distribution for probabilities? Well, probabilities are constrained between 0 and 1. If you model something with a probability of 2, your model's going to fall over. And you can't have a negative probability either. If you were to assign a probability a normal distribution, well, what are the limits of the normal distribution? Plus or minus infinity. So you could, if you draw enough samples, draw a negative probability or a probability above 1. So don't ever assign a probability a normal distribution, because if you run enough simulations, in the extreme, you're going to draw a value that's below 0 or above 1. The beta is perfect because it's constrained between 0 and 1. So the beta is an ideal distribution for a probability. What about a cost? So costs aren't constrained between 0 and 1, but they are constrained at 0. You don't get negative costs. So you don't want a distribution that could go negative, like the normal distribution, but you want one that can go above 1. And also, typically what we observe are costs that, most people have a sort of relatively moderate cost, but you get those outliers who incur huge costs. So the sort of distribution that works well for cost data is something that can have a long tail and is constrained at 0. It must be positive. So the log normal distribution is a good contender, or the gamma distribution. And which one you should pick depends on what your data looks like. And then finally, a utility value. So utilities cannot exceed 1. So 1 is perfect health. That's the highest utility you'll ever have. 0 is equivalent to death. So usually, your utility lies between 0 and 1. But some people consider to be worse than death. So if you assign a utility a beta distribution, that's OK. You constrain between 0 and 1. They're all plausible utility values. But you're ignoring the potential to have states worse than death. So if you're modeling a disease where some patients might have a really, really poor health state that might have a negative utility value, don't assign that a beta distribution. Instead, consider the disutility. So let's say the utility value is 0.1. Well, the disutility is 0.9. Yeah, it's 1 minus the utility value. And give that a gamma distribution, because the gamma is constrained at 0. So if you model the disutility with a gamma, you then have a limit of 1, but you can get negative values. So that's how we assign distributions to utilities that could be negative. But that's all technical details. That's how you would assign the probabilities. Once you've done that, once you've assigned distributions to all your parameters, you can then run your probabilistic analysis. Let's go back to the deterministic analysis. Notice how we have, in this example, we have exactly 0.7 is the probability of a healthy patient remaining healthy with treatment A, and 0.2 is the probability of a healthy person becoming sick with treatment A. Look what happens when we run this model probabilistically. The very first simulation that we draw, we get slightly different values out. So what I've done here is I've assigned probability distributions to all the parameters, and the means of these distributions are the same as in the deterministic analysis. So the mean of the distribution here is actually 0.7, but it has a distribution around it. And the first time we draw a value, we get slightly below 0.7, we get 0.67. The mean of this distribution is 0.2, but the first draw we take from that distribution is a bit higher, it's 0.28. So because we have slightly different probabilities and slightly different costs from the mean, we end up with slightly different total costs, total QALYs, and in turn the incremental net monetary benefit. But in this case, for this first simulation, treatment A is still cost effective. But we don't just run one simulation, we run thousands of simulations. So the next simulation, we draw different values from all of these distributions. And in this case, we end up with quite a different result. So looking at the values that we drew, it looks like we have a lower cost for treatment B in the healthy state than we did in the first simulation. We also have a much higher utility for patients who are healthy than we did in the first simulation. And it just so happens that when you run the model with these values, these inputs, you end up with treatment B being, again, quite a lot cheaper, but also more effective on this simulation. So treatment B is cost effective. But that's the second simulation. We need to keep running simulations. And for this example, I ran 10,000 simulations. The final simulation, we drew different values, and we found that treatment A was cost effective on that simulation. In order to get our results, we need to average over all of these simulations. When we average over all these simulations, we end up with 0.7 being the average, 0.2 being the average. So we've run so many simulations that when you average over them, we end up back with the same input parameters. But the results are slightly different. The total cost, the total qualies are slightly different than they were in the deterministic analysis. If you look at that incremental net monetary benefit, 4,091, it's very slightly different to what it was in the deterministic analysis. But we still come to the same conclusion, that treatment A is cost effective. Why would you go to the trouble of running a probabilistic analysis? Well, it has some benefits. So in addition to reporting just the average results, so instead of saying the ISA is $40,000 per quality, and that's it. If you run a probabilistic analysis, you can also report the uncertainty around that. So you could report a confidence interval around your ISA. You could report a confidence interval around your estimate of the incremental net monetary benefit, or around the total costs or the total qualities. So you can describe the uncertainty in your results. You can also estimate the probability that each strategy is cost effective. So rather than just saying strategy A, treatment A is cost effective, that's the end of it, you can actually say, well, you know what? On average, it was cost effective. But on some of my simulations, treatment B was cost effective. So there is some uncertainty in this finding that treatment A is cost effective. On 56% of those 10,000 simulations, I found that treatment A was cost effective. But on the remainder, 43%, treatment B was cost effective. So if you're a decision maker and you need to decide, well, which of these two treatments should we pay for? On average, looks like treatment A. But you might be wrong. You might be wrong. We're not certain that treatment A is cost effective. Also, you might take issue with using $50,000 per quali as the cost effectiveness threshold. Why not 40,000 or 60,000? So you can actually calculate that probability that a strategy is cost effective for a range of different willingness to pay values. And you end up with what we call a cost effectiveness acceptability curve, or a CAC. And this is what a cost effectiveness acceptability curve looks like. So we can see that if your willingness to pay is very low, 0, if you as a healthcare decision maker are not willing to pay anything for health outcomes, it's quite extreme. Let's say that was the case. Well, then you would go for treatment B because it's the cheaper one. Sure, treatment A might be more effective, but you don't care about paying for health outcomes. You're not willing to pay anything. So you're always going to go for the cheaper strategy. So in this case, B. So there's a 100% probability that B is cost effective if you have a very low willingness to pay. At the other extreme, if you're willing to pay a lot for health outcomes, then you'll generally go for the more effective strategy regardless of the cost. And in this case, that's treatment A. But somewhere in between, you're uncertain. You're uncertain about which strategy is the more cost effective. So the CAC curve, it just lets you as a decision maker say, well, you know what, I'm willing to pay $50,000 per quali, and, you know, on average, treatment A is cost effective, and it looks like probabilistically treatment A is more likely to be cost effective, but there's still that uncertainty. There's still that chance that B is cost effective. This brings us on to value of information analysis. So we talked about how in a probabilistic analysis, input parameters are uncertain. So the outputs are also uncertain. The costs, the estimated costs, qualies, the incremental net monetary benefit, and that decision about which treatment is cost effective can differ across Monte Carlo simulations. So in some of those Monte Carlo simulations, A looks more cost effective, and in other ones, B was cost effective. Now, if you were to do enough simulations, let's say you did an infinite number of simulations, then just by chance on one of those simulations, you're going to draw the true value of every parameter in your model. All right, so let's think back to, say, that probability of being healthy and remaining healthy with treatment A. It had a mean of 0.7, but then we said, oh, well, we're uncertain about that. So we assigned a probability distribution. Well, the truth has to lie there somewhere, right? The true value might be 0.6, or it might be 0.8. We don't know what the true value is. We're uncertain. But there is a true value. And the same is true for all of the other parameters. There is a true value, but we're uncertain. And we have a probability distribution, and the truth lies somewhere in that distribution, but we don't know where. But if you were to run enough Monte Carlo simulations, then just by chance, you would draw the true value for every parameter. And that would give you the true result. It would tell you which strategy is truly cost-effective. The problem is we don't know which one. Right? We don't know which of those thousands of simulations is the truth. All of them are equally likely to be the truth. Assuming that you've parameterized your distributions appropriately, every single one of those Monte Carlo simulations has an equal probability of being the truth, but we don't know which. And this is a problem, because I showed you just before that on average, treatment A is cost effective. And on simulation 1 and simulation 10,000, treatment A appeared cost effective. But on simulation 2, treatment B appeared cost effective. What if simulation 2 is the truth? What if simulation 2 was the one where we drew the true values of all these parameters? So actually B is cost effective. But because of our uncertainty, we think that A is cost effective. Well then, as a decision maker, you'd make the wrong decision. So our imperfect information, our uncertainty about the true value of all these parameters has a cost. We'd make the wrong decision. So if we were to have better information or perfect information about all of these parameters, that would help us avoid making wrong decisions. It has value. And that's the basis for value of information analysis. Information has value because it can avoid making wrong decisions. That's where the value comes from. So let's go back to the results of our probabilistic analysis. If the true simulation is number 1, the cost-effective treatment is A. If it's 2, the cost-effective treatment is B. If it's number 10,000, the cost-effective is A. Because the decision maker has no idea which of these simulations is the truth, all they can do is go on the average results. And on average, A has positive incremental net monetary benefit, so A is the cost-effective strategy. But there's always the chance that they're wrong. What is the cost of a wrong decision? So let's suppose that the first simulation is the true simulation. We don't know that, but let's suppose that it is. And that's unknown to the decision maker. In that case, because on simulation 1, A was the cost-effective strategy, it means that the truly cost-effective treatment is A. And the incremental net monetary benefit is that was estimated on simulation A, which was 7,600. Right? That is the benefit, the monetary benefit of going with A rather than B. Now on average, when we average over all the simulations, A also appears cost-effective. The average incremental net monetary benefit is 4,000. Based on the average results, the decision maker chooses treatment A and implements A rather than B. Now that's lucky. It's lucky that they went for A because A is truly cost-effective. Now the decision maker thought they were going to gain $4,000 worth of benefit over B. Actually, they're going to gain 7,600. So that's just lucky. That's really good for the decision maker. They picked the right strategy. It was the correct decision. If, hypothetically, they had perfect information before making that decision, they would also have picked A. They would have known that they would have gained 7,600, not 4,000, but they would have still made exactly the same decision. And the true benefit of A is that was estimated in simulation 1, which is a benefit of 7,600. So you know what? If you had perfect information, it would make no difference. None. You'd still make the same decision. So if simulation 1 is the truth, perfect information has no value to this decision. The same decision would have been made. Now, what if the second simulation is the true simulation? That was the one where B was more cost-effective. So B has an incremental net benefit of $36,000. So if the second simulation is the truth, you're losing $36,000 of net benefit by going with treatment A rather than treatment B. But the decision maker doesn't know that that's the truth, and based on the average results, they choose treatment A. And that's the wrong decision. If perfect information was available, they would have changed their decision, and that would have resulted in an additional $36,000 of net monetary benefit. So the imperfect information had a cost of $36,000. So imperfect information has a cost of $36,000 if simulation 2 is the truth, but it has a cost of 0 if simulation 1 is the truth. So what's the expected value of perfect information? We don't actually know what the value of perfect information is. It might be 0, or it might be positive. We don't know. But we can calculate the expected value of perfect information. So for those simulations, including 1 and 10,000, where the cost-effective treatment for that simulation is exactly the same as what is implied by the average results, perfect information has no value. Right? So the value of perfect information is 0 for those simulations. For all the other simulations, the value of perfect information is equivalent to the incremental net monetary benefit of the other strategy. Right? So for simulation 2, it's that $36,000 that you would have got if you'd picked treatment B. So it follows that perfect information either has positive value on some simulations or it has 0 value on the other simulations. And in order to calculate the expected value of perfect information, we just average over all the simulations. Because all of the simulations have an equal probability of being the true simulation. So we just take the average. So if we go back to here, we can see that for simulation 1, the incremental net monetary benefit is positive. A appears cost-effective. So the value of perfect information for simulation 1 is 0. It would make no difference. For simulation 2, B appears cost-effective. So if we had perfect information, and if, with this perfect information, we were able to see that simulation 2 is the true simulation, then that would gain us $36,000 of net benefit. And so on, all the way down to 10,000, where if 10,000 was the truth, we'd go for A, and so perfect information would have no benefit. And so we average over this final column. There's lots of zeros there, but there's also lots of positive numbers. So if you average over that, you're going to get a positive number. And in this case, it's about $7,000. So what does that tell us? It tells us that if you could click your fingers and remove all of the uncertainty in all of your parameters, that would be worth, on average, $7,000. Now, what's the implication of that? Let's first talk about the probabilistic sensitivity analysis. What's the implication of that? So we know that in the real world that input parameters are uncertain. We are never certain about what the utility is associated with any particular health state. We're very rarely certain about what the costs are associated with any particular health state or the probability of moving from one state to another. We're always uncertain. So what that means is that we should always use probabilistic analysis. We shouldn't be using deterministic analysis where we just put fixed values into our model. We shouldn't be doing that. By doing probabilistic sensitivity analysis, it allows for consideration of the uncertainty not only in the inputs but also in the results. This is why it's really important to do probabilistic analysis, even if you don't care about uncertainty, even if you don't care about representing, giving the confidence interval around your results. You don't care about that. If your model is nonlinear, so a Markov model, a state transition model, that's a nonlinear model, or if there's any correlation between parameters, then your deterministic results are going to be biased. If you incorporate uncertainty in your inputs, you'll actually get a different result. So it's really important that you do probabilistic analysis if you have a Markov model or any other state transition model that's nonlinear. It's really important to do probabilistic analysis. Even if you don't care about the uncertainty around your results, you don't care about value of information analysis, you're just going to get the wrong ISA. You're going to get the wrong estimate of the total costs to total qualities. So it's important to do probabilistic analysis. But you need to be really careful how you interpret the results of a probabilistic analysis. It's very easy, it's very tempting to think that the strategy with the highest probability of being cost-effective is the most cost-effective, and that's not true. So to give an example, I'm going to propose that we play a game. And I'm going to take a fair die, 6-sided die, and I'm going to roll it. And if I roll a 1, 2, 3, 4, 5, then each of you has to give me, or I will give you, each of you, $1 if I roll a 1 to a 5. And if I roll a 6, then each of you have to give me $1,000. Okay. the probability of you winning this game is actually 5 over 6. It's over 80%. So if you were to do a cost-effectiveness analysis on this game, should you play or not, the probability that playing is the cost-effective strategy is actually over 80%. So anyone want to play this game? You're very likely to win. No? Because the expected value to you of playing the game is negative. All right? There's a 5 in 6 chance that you'll win $1. There's a 1 in 6 chance that you lose $1,000. Right? So this is really not something you should be doing. But if you only based your decision on the probability of it being a good decision, the probability of winning, you would go for it. If you based other decisions in your life on the probability of being right, then you'd never wear a seatbelt, you wouldn't buy insurance. You know, I buy insurance for my house knowing that it's probably a waste of money, and I hope it's a waste of money. I hope I don't need to claim on it. I hope that every year I just waste however many $100 it costs. But I do it because there's a small chance that I'll get a huge return from it. But if I base that decision on just the probability of it being the right decision, I wouldn't do it. I wouldn't wear a seatbelt when I get in a car. Probably don't need it. But I do it because the cost of wearing it is tiny and the benefit if I need it is huge. So you shouldn't make decisions based on the probability of being right. And that raises the question, well, what's the point of the CIAT curve? What's the point of even considering the probability of a strategy being cost effective? Well, I think what I hear from decision makers is that they want to know that. There's a difference between knowing with certainty that a strategy is cost effective, that it's going to save you this amount of money and it's going to give you this number of QALYs or other health benefits, and just being uncertain about that. But how you take into account that uncertainty is complex. You have to be very careful with how you interpret that probability. What about value of information analysis? What's the implication of that? So I mentioned earlier that the value of having perfect information about all these parameters in the model was, I think it was $7,000 in that example I gave you. Well, this has implications for whether we should conduct further research. So we've just worked out that the expected value of perfect information for every parameter is $7,000 per patient. What if someone proposed a trial? They said, you know what, this uncertainty is a problem, we need to do a trial in order to get better information about one or more of these parameters. You know, your trial is essentially going to reduce the confidence interval around some of those parameters. And this trial costs more than the EVPI. Well, the trial might be still worth doing if you're going to use it for other decisions in the future. But for this decision, the amount that you're spending on the research to reduce the uncertainty is actually more than the expected cost of the uncertainty. So EVPI, expected value of perfect information, is actually quite useful if you're planning to do further research. It can help rule out research activities that are too costly, where the results, although they're useful, the value of those results in reducing that decision uncertainty is just not justified by the cost of the research. You can also use more advanced techniques to work out the EVPI for particular parameters. So rather than just every parameter in the model, you can work out the EVPI for a particular parameter. And that allows you to prioritize research. So let's say we have a few $1 million available to do some research. Which of those parameters in the model should we do the research on? Is it the probabilities? Is it the costs? Utility values? Are there particular parameters in this model for which the uncertainty has a very high cost? So expected value of perfect information analysis allows you to prioritize future research. And the value of the expected value of perfect information depends on how close the ISA is to the willingness to pay, or equivalently, how close that incremental net monetary benefit is to zero. If your decision is on a knife edge, typically the value of perfect information will be much higher. If you have a slam dunk where the ISA is $1,000 per QALY or $1 million per QALY, where it's obvious whether something's cost effective or not, usually reduce the uncertainty around a parameter would not tip the result because you're just so far away from the tipping point. So then you'd expect the value of perfect information to be quite low. But when the decision is on a knife edge, then the value of perfect information is usually quite high. And that's when it might be useful to do this sort of work to estimate the value of perfect parameter information around particular parameters in order to prioritize research before you go and make a decision, if possible. Here's some further reading. There's a paper on probabilistic sensitivity analysis. There's also a paper here on using value of information analysis. And for those of you who are interested in building your own decision models and doing probabilistic analysis, I'd strongly recommend you read this textbook here. It's quite a new textbook, and it has a very nice section on which parameter distributions to use. How should you choose whether to use a beta distribution or a log normal or a gamma? It's a really nice section on that, and it's quite easy to read. So that's it from me. Thanks very much.